So now this is a bit of a monotonous topic, really, on a Sunday afternoon. So I've cut my slides down a little, and we're going to spend more time talking about clinics and less time talking about the evidence synthesis. But it is really important as clinicians that you understand a few things about the way evidence is brought together and about how we apply it to practice. So I think I showed you the slide when I first started about how when you bring the evidence together, you have the concept of getting evidence from research, combining it with clinical expertise when you bring all of this together in an actual guideline. One of the things about evidence-based practice, and Dura was just saying there's an Indian guideline on the use of oral contraceptives in PCOS coming out. One of the things about evidence-based guidelines, and I had a long discussion with the task force at the US Endocrine Society a couple of years ago, because they don't follow good evidence-based practice in their guidelines. So they have what we call eminence guidelines rather than evidence guidelines, and I think I referred to that yesterday. They have a large number of experts, usually only from the US, who sit down and say, this is what we think, usually doesn't consider ethnicity or other issues, and that becomes the guidelines. That's not the way Europe does it anymore. It's not the way the UK or Australia do it. They have a much more rigorous process to make sure it's really fair and reflective. And so I think we've finally got some traction, and the US Endocrine Society and others, including American Society of Reproductive Medicine, are now completely reviewing the way they do guidelines. And I'll talk a little bit about why. So it's not so much that you have to have evidence for every question that you ask, and your dynamic discussions today about infertility treatment are evidence for that. You will have all sorts of combinations that you'll use clinical judgment. But the most important thing is that anybody who provides you with guidance has followed a reasonable process, and that you can understand what that process is. What were their conflicts of interest? How did they assess the evidence, and how did they report it back to you? So the irony is that evidence-based guidelines follow a logical process to start by looking for the evidence, and they'll tell you what it is if they find them and make an evidence-based recommendation. If they don't find them, then they'll give you a clinical consensus recommendation, which means they're telling you as an expert what they think. And so you need to take into account whether that's going to guide your practice when you understand it. So evidence-based guidelines follow and report on the process at every step, and you can understand why we've come to the recommendations and whether or not you wish to follow them. Non-evidence-based guidelines might have lots of evidence in them, but they haven't followed a logical process, and they can interpret the evidence any way they like. So the main point about doing evidence synthesis and bringing the evidence together is obviously to improve patient outcomes, not to promote an individual's research, but to improve patient outcomes, to promote standard care and reduce variation in practice, to be able to work out what the healthcare costs are, promote evidence into practice, and support education and training. So they're never meant, and none of the evidence directly will be exactly the same as your patient. In exactly the same context, you, I'm sure, have a lot of evidence from white populations or other populations that may not be applicable to you, so you need to use your clinical judgment, and it will never replace that. So when we put all these things together, and I'm just going to go through this reasonably quickly, is that we actually start by deciding what it is we're going to do, whether it's defining the scope of the review of evidence or the guideline. What is it that you're actually going to cover in your guideline or your evidence synthesis? So it's very important to do, because you can get lost if the questions or the scope of the activity is too big. You then bring the group together, and if you're going to develop guidelines or do evidence synthesis and interpretation these days, it's very appropriate and useful to have consumers in your group. And when we first did this and we put a patient or a consumer in the room with our experts, they really struggled to see why a patient would want to listen to a whole lot of interpretation from evidence, and how could they possibly value add. But in fact, they actually made a very big contribution, and would often sit and say, that question's not so important to us. We really would like to know about thinking about it one way or the other, and the way we expressed the recommendations were also quite useful. They had a significant role in deciding what we covered, what we did our evidence synthesis on, and what was important. Then we defined the topics, and the most important thing, and I want to point this out, is that the rule of best guideline development is you should always search for existing guidelines and then adapt them to your population. You shouldn't start the whole process again, because it wastes very valuable resources. And then if you need to, and there isn't a guideline to adapt, you can go through all of these other local processes. If there is a guideline, there's a particular process called the adapt process through which you can adapt it for your population. So in the Indian context, there are many guidelines where using the adapt process might be very appropriate, where you bring together your own groups, look at your cultural and ethnic data and see how you might want to change those recommendations. For example, in our case, I suspect that the issues around acanthosis nigricans are probably going to be one of the main areas that you'll differ in terms of diagnosis. So you always start by adapting what's already there, and that includes a systematic review or evidence. Find what's already there and then update it if you need to, rather than starting all over again. Systematic reviews and guidelines are an awful lot of work, and you need to do them reasonably well. So you need a good process, a good team, and you need to adapt it to your population. One of the problems, and this is where the American Society of Reproductive Medicine got themselves in trouble recently, was that they didn't follow any of those really good processes. They just got a whole group of experts together who said, this is what we think you should do. And then the quality of their guidelines were assessed and were found to be relatively poor. And in fact, they were actually recommended as not to be recommended to guide practice. So what's happening now is if you do have a guideline and it's not been well developed, and you're advising people to undertake certain forms of clinical practice, then there is an issue about being able to defend that. So this was actually one of the evaluations of the quality of clinical practice guidelines and evidence synthesis for assisted reproductive technology. This was actually the one that highlighted that most of the guidelines in this area were not very good quality. So overall the quality was suboptimal. They used a tool called the Agree-To, and they ranged between 37 and 80%. Luckily ours was the one that was 80%, or was on the high quality range. But the point is that the one that was recommended as not guiding practice was the American Society of Reproductive Medicine. So just because they're prominent societies and groups, if they don't follow a reasonable process and they don't meet these list of areas, then they're not to be trusted to guide practice necessarily. So have you defined what scope, whether it's a systematic review or a guideline? Have you got the right people involved? Have you looked at how you develop the process? This is a recipe. Anyone can do this. It's just following a very detailed process, but you can do it at quite good quality. Is it clearly presented? Is it applicable? And this is where it becomes relevant in your population. If it's not, you need to adapt it. And is it not influenced by pharma or other relevant groups? So I did show you this the other day, but these are the steps that you go through, and the systematic review of the evidence is done here. You need development groups. This is whether you adapt the international guidelines to your context, is that you will need to look at, in your case, you would need to establish a new guideline development group. All this has already been done, although some of the evidence that Chandrika showed you yesterday about the ethnic differences would be very valuable to bring to the table. And then the Indian group would come and look at how they would formulate guidance, or Southeast Asian group, how they would formulate guidance that's slightly different based on your ethnic group. So it's a much simpler process that takes about 5% of the total effort to write the original guideline. As I mentioned, we had multiple groups, but when you do this, for example, if you're going to adapt the international guideline, what you'll need to do is decide which areas it's actually relevant in. For example, menstrual cycle irregularity in adolescents you may think is fairly similar, and that may not be an important issue. However, when you come to metabolic features, then clearly there will be differences in this population. So it's about understanding what the scope is of what's important to you. When we do a systematic review, and I imagine, I don't know, do you have many people who are trained in evidence synthesis or systematic reviews in India? Okay, so the thing about evidence synthesis is it's not rocket science. So whilst the guideline has got a massive amount of work, if you ask me how much of that physical work I did myself, yes, it's taken a reasonable amount of my time, but actually most of it's done by a team of people who just know how to do evidence synthesis. So once they're trained, which is not difficult, this could be done very easily in your context, and nearly always yields very high impact publications, because it's a good appraisal of the literature. So I would imagine when your wages are not particularly, excessively high, that actually quite a bit of this could be done in Southeast Asia and would be applicable more broadly. You have to determine in your systematic reviews who the participants are. For example, are you looking at only Southeast Asian or all women? What the intervention is, for example, the oral contraceptive pill, what they've compared it to, which might be a different oral contraceptive pill, and what outcomes you were looking at. Now, in the past, the experts just decided whatever outcome they wanted to choose. That's no longer acceptable. We have to ask clinicians and we have to ask patients about what outcomes they think are important. And so in our case, we actually got a very large number of women and health professionals to rate what was most important to them when we did the work that we've done. And then once we've done all of that, we then make the recommendations, as I said, and the most important thing is when you look at any guideline, you should look at whether they're making an evidence-based recommendation or a clinical consensus recommendation or a practice point. If it's an evidence-based recommendation, you should trust it to guide your practice. If it's a clinical consensus recommendation, you can consider it. And if it's a practice point, it's just there to help you. So the most important thing is that you should, whenever you get a guideline, have some understanding about what the body of evidence is. Can it be trusted to guide practice? Is it trusted in most situations? Can it just inform you? Or really there's not a lot of information. The problem is most clinicians just look at a guideline and read all of the recommendations the same way. Whereas the evidence for this last one is just what a group of people think, as opposed to this one, which is really what you should be doing. So just be aware when you read anything that's providing guidance that there's a different level. So I'm going to talk to you a little bit about what might be directly more relevant to you in this context is that the big problem is how many of you read guidelines on a regular basis to guide your practice? You can be really honest. Okay, that's more than I thought. The problem with guidelines is they're huge. I'm sure I'm going to be the only person who ever reads our 2,000-page evidence synthesis report, and I hope nobody else has to read it. The 190-page guideline, again, I doubt very many people will read it. The 17-page summary, maybe, but actually the 2-page flip chart that brings it all together is probably what most people will read. And so it's a matter of how we design those and get them out and make them available. So I think the most exciting thing that's going to come out of the guideline from my point of view is the patient app. And we hope that will actually be freely available through Southeast Asia. We're actually working with Apple and Google at the moment about how we make it at a minimum cost in Western countries, in developed countries, but actually hopefully free of charge on their platform throughout the countries that it may be appropriate. So I'll talk a little bit about the app in a moment, but it's developed on what's called a question prompt list, which is the 97 most important questions women came up with in many different iterations. There'll be content for websites, and we'll share that with the PCOS Society of India, all of which is freely available and can be translated. There'll be small fact sheets, podcasts, interviews with people who are involved, information from patient experience for women, and that will aim to be on your resources. It would be women from Southeast Asia and experts from Southeast Asia who've been involved in the guideline. There'll be lots of resources, and that will come from societies as well, and those algorithms and things that I mentioned. There'll also be online education modules, and all the health professionals who complete those will not only get a certificate, but actually will then be listed on the app as a trained health professional in their region for women with PCOS. There'll be modules for undergraduate training, and if any of you heard of a core minimum data set? Okay, so just very briefly, one of the problems is every time we do a study, and all the studies you've just presented here, everyone measures things differently. So they might be reporting menstrual cycles, and sometimes they report them as the 5th centile and the 95th centile. Sometimes they report them in different ways. Sometimes they use different doses. Sometimes they use different durations. And you just can't compare the work that's done out there to guide your practice. So there's a process now that started in the UK where you bring clinicians and patients together and agree on the most important endpoints, how to define them, how to measure them, and every study and every clinic that works in this condition measures those endpoints. So for diabetes, we know what they are. For gestational diabetes, we know what they are. That's actually happening now for PCOS, and we'll know what they are. And when you set up your clinics, it's really useful to collect those data, because then you can compare your practice across clinics, but also across the world. So that core minimum data set's being developed at the moment, and it'll be housed in an international data hub, and anyone who's interested, and we'll talk about this in the research collaboration, will be able to log on in their clinic and enter that data and be able to, it'll be de-identified, you'll just have a number. You might be practice number 79, and you'll be able to see how your outcomes in practice 79 compare to other practices. And so there will be both an international data hub that will be freely accessible for clinical data, but more importantly, every patient who uses the app who doesn't dissent from their data being involved, all their data will be collected in a data hub. And so we'll be able to provide you with the data about what women from India are really interested in, what they want, what they need from the app. We're also developing new models of care, which Rob and I are going to talk about in a moment, but there's a whole range of ways to get the guideline out there, and we're happy to have any suggestions and any partnerships that will work on that. This is what the app will look like, except in your case it will not have a white woman on it. We would hope that in the different regions it'll actually have appropriate women, or at worst case scenario, it may just have a diversity of women. So they'll have, they can look at all of these different things, including looking at their diagnostic features, how to prevent complications, and this will link to the people who've done the online course. So as I said, it's only been, some of this data has only just been presented, and it'll be launched formally at ESHRE. We'll send the information through to Duru for the PCOS Society of India. It'll be on your websites. All the resources will be available. I've just got to work out with Duru who's going to do the translation, but it'll be available in English. We've actually just pulled off a huge coup, so it will be in human reproduction, fertility, sterility, and clinical endocrinology at the same time, and will be freely available online from those sources. So all the resources will be free and for everyone to use. So whether you're doing evidence synthesis or reading systematic reviews or Cochrane reviews or reading guidelines, you just need to make sure you have a quick look at the methods and make sure they've done them appropriately, and whether they use the terms of evidence-based or clinical consensus or clinical practice points when they're recommending guidance, and whether they've actually done a good job of explaining to you clearly about the methods that they used.